The 2025 NEI Spring Congress attracts mental health practitioners from around the world to engage one-on-one with expert faculty and driven colleagues, like-minded colleagues. Join us to experience an unrivaled educational program full of practical takeaways, where you will learn the latest advances in psychopharmacology and explore cutting-edge research on treatment strategies, side effects, drug-drug interactions, and management. If you haven't done so yet, please register today to join us in person in Philadelphia, my beloved hometown, or online via simulcast May 8th through the 10th. You can use discount code NEIPOD25, that's NEIPOD 25, to save $100 on your registration at nei.global/SP Congress 25P. That's nei.global/SP Congress 25P. Discount is good on new registrations only.
Welcome to a special Pediatric Psychopharmacology series of the NEI podcast, hosted by Dr. Jeffrey Strawn. Dr. Strawn is a professor of pediatrics and psychiatry and behavioral neuroscience at University of Cincinnati College of Medicine, with expertise on mood and anxiety disorders in children and adolescents. In this series, he will engage with fellow experts to discuss important issues related to pharmacological treatments for psychiatric conditions in pediatric patients.
Welcome to the Pediatric Psychopharmacology series. I'm Dr. Jeffrey Strawn from the University of Cincinnati, and I'm here with my good colleague and friend, Dr. Robyn Thom, who is an assistant professor at Harvard Medical School and a staff psychiatrist at the Massachusetts General Hospital, Lurie Center for Autism. Dr. Thom specializes in treating children and adolescents with autism spectrum disorders and other neurodevelopmental disorders, including anxiety, as well as mood disorders. Welcome, Dr. Thom.
Thank you.
And we're going to be talking about pharmacologic management strategies in autism. But I guess really the first question is, when we talk about pharmacologic treatment of autism, what are we actually treating? Are we treating autism, or are there specific components of the disorder?
That's such a great place to start. But just as a reminder, the main core symptoms of autism are social impairment and repetitive behaviors, and we actually don't have medications that are effective for treating either of those two core symptom domains. So when we talk about psychopharmacology for autism, we're really talking about treating associated symptoms of autism, such as irritability or other mental health conditions, such as ADHD, mood anxiety, mood disorders, or anxiety disorders.
So we're really talking largely about transdiagnostic symptoms that may be associated with ADHD or an anxiety disorder. In other words, a comorbidity.
Exactly.
So this is a bit confusing for me, Dr. Thom, and I'm hoping you can maybe walk me through this, because I know that we have some medications that are FDA approved for certain aspects of autism, but it sounds like largely what we're talking about is treating other disorders, generalized anxiety disorder that perhaps is co-occurring with an autism spectrum disorder, or ADHD that is comorbid with ASD. Is that correct?
That's exactly right.
So what are those FDA-approved treatments that we have?
So there are two medications, risperidone and aripiprazole, which are FDA-approved for treating one very specific symptom associated with autism, and that's called irritability. Irritability in this context can mean behaviors such as self-injury, verbal or physical aggression, property destruction, really bad tantrums, or really severe mood symptoms such as irritability, quickly changing mood, low frustration tolerance.
So now I'm even more confused. So irritability is also a symptom of generalized anxiety disorder, major depressive disorder, a manic or mixed episode associated with bipolar 1 disorder. So how might I distinguish irritability in ASD from irritability that goes along with one of those other conditions?
It's really, really tricky. So I don't actually jump straight to risperidone or aripiprazole when I see a kid in my office who has autism and really bad tantrums. There's actually a series of steps that I always work through first. The first thing that I do when I see a kid who's coming in with bad irritability is I like to be really sure that there's not a medical issue or a physical component that's contributing to some of the behaviors, especially in kids who have less ability to tell us about their physical discomforts or symptoms verbally. It's really key to be sure that there's not something like a headache or constipation or an ear infection contributing to these behaviors. Sometimes the type of behaviors, so for example, if a kid is banging their head, might point to the area of discomfort, but other times it can be pretty unrelated. So it's really important to collaborate with our primary care colleagues around this issue. Once we're pretty sure that there's not a physical contributor, then it's important to take a step back and really try and understand the behaviors in a detailed way to understand if the behaviors are some sort of communication. So, for example, if the kid is having a meltdown every time they have math class, then it may be related to getting out of math class. There can be a number of different what we call functions for challenging behaviors, such as escape, attention-seeking, access to some tangible object. And our behavioral therapists, our board-certified behavioral analysts, they are really instrumental colleagues and collaborators in trying to understand the function of the behavior. Because sometimes behavioral approaches can be very effective and eliminate the need for using medications if the behavior is really serving some sort of function. We also really want to make sure that we're optimizing the child's ability to communicate. People with autism have varying abilities to communicate. Some children are fully verbal, some children are completely nonverbal. So no matter where the kid lies on that spectrum of communicative ability, we want to be sure that they're able to tell us what's going on and what they may need. So once you've worked through those first three steps, then I am trying to assess the child for a psychiatric or a mental health comorbidity. Just as you were saying, irritability can be a symptom of anxiety, of mood disorders, ADHD. So then you're really trying to look at the full picture of mental health symptoms and deciding whether it fits into one of those DSM-5 mental health conditions. And if one is present, then we treat it with pretty typical medications for each of those disorders. Only if a clear mental health comorbidity is, if one is not present, you really can't convince yourself that there's a clear mental health condition there, then you might consider treating non-specific irritability with a medication such as risperidone or aripiprazole.
Thanks. That makes a lot of sense, Dr. Thom. As I think, though, again, about those symptoms and perhaps the specific medication treatments that we may use, although certainly you've emphasized the importance of the behavioral interventions, maybe we can walk through a couple. So for me, when I'm often seeing patients with autism spectrum disorder, there may be anxiety and often a degree of rigidity and sometimes perseveration. But phenomenologically, it feels different from that anxiety that I might see with an anxiety disorder, or the perseveration or rumination, perhaps, that I might see with obsessive compulsive disorder. Can you maybe help us understand how you would approach that anxiety-like phenomenon, for lack of a better description, or maybe even give us a better description?
Yeah, so I think what you're getting at, Dr. Strawn, is how anxiety may overlap with some of the restricted repetitive behaviors of autism. For example, one of the diagnostic criteria for autism is a strong need for sameness. So these are kids who want to be taken to school every day using the exact same route. And if there's construction and the route is changed, kids can have a really hard time. They may want to greet their teacher in the exact same way at the beginning of each school day. If that routine is interrupted, kids with autism can become quite rigid and irritable. When we see behaviors like that, I really see them as being core symptoms of autism and wouldn't necessarily place an additional anxiety disorder diagnosis on top of that. So if we think it's really core autism, that's not an area where I would try to treat with a medication, because we really don't have good medications for those repetitive, rigid thinking patterns and behaviors.
So what I'm hearing you say is that maybe you wouldn't reach for an SSRI in that situation.
That's right. And we actually have data showing that SSRIs really don't help in those situations.
Interesting. So let's talk about attention, because I certainly know that ADHD is often comorbid with ASD, but as you've already alluded to, there's tremendous overlap between many symptoms or even deficits associated with these other disorders and core features of ASD. Maybe you can walk us through how you would disentangle those and perhaps also how you might treat them.
Right. ADHD is very common and highly comorbid in kids with autism. Probably something like 60 to 70% of kids with autism meet full DSM-5 diagnostic criteria for ADHD. So that's a situation where we really don't try to parse what's core to autism versus what is ADHD too much. I would generally take the same diagnostic approach for diagnosing ADHD in a child with autism as I would in a child without autism. The treatment approach is also relatively similar. There are 3 medications that we have randomized controlled trial data for ADHD in kids with autism. Those are immediate release methylphenidate, extended release guanfacine, and atomoxetine. Each of these 3 medications is helpful in a subset of kids with autism and ADHD, roughly 50%. So the long story short is these medications work for some kids with autism. They're not quite as effective as they would be in kids who have ADHD alone, but they certainly can be helpful. And that's a comorbidity where we really want to treat if it's there, because attentional impairments only make autism look worse. So what I mean by that is ADHD alone can be really socially impairing, because if a child can't sit still enough for long enough to attend to social cues or learn social skills or pay attention to the conversation, then they're pretty socially impaired. So you want to take that off the table if you can pharmacologically.
And I would also imagine, based on what you just described, that treating the attentional impairment would also help in terms of some of the psychosocial interventions.
Absolutely.
So, Dr. Thom, I'd like to maybe move on to some of the specifics of psychopharmacologic treatment. We've talked about the 2 FDA-approved treatments for irritability associated with ASD. Maybe you could walk us through how you decide among those treatments or relative to other treatments in addressing irritability.
Thank you for asking that. Funnily enough, in my practice, I typically don't start with risperidone or aripiprazole, even though they are the 2 FDA-approved treatments. And the reason for that is because I never take the decision to start an antipsychotic lightly in a child just because of the great burden of possible side effects. So typically, if I really need to treat nonspecific irritability in a child with autism, I'm actually starting with an alpha agonist. So I typically start with extended release guanfacine, simply because we have that safety data in the ADHD trial for kids with autism. If guanfacine is not working, and the irritability is still really at a level where it's impairing the child, they're not able to access psychosocial treatments, they're at risk of being kicked out of school, they're a threat to their families, then I'm really deciding between risperidone and aripiprazole. Both these medications are incredibly effective for treating irritability in kids with autism. The number needed to treat for risperidone is 2. And the number needed to treat for aripiprazole is 3. So they're both really, really effective medications.
Dr. Thom, can you remind our listeners what NNT actually is and how to interpret that? I get the sense that lower is better based on what you've just described.
Of course, yeah. So what number needed to treat means is the number of additional patients that need to be treated for one person to have benefit. So lower numbers are better. Because both have such low numbers needed to treat and are effective, I really decide between the 2, risperidone and aripiprazole, based on the side effect profile. Both of these drugs have similar side effect profiles in as much as they can increase appetite and all the problems that come along with weight gain and increased appetite, as well as the risk for tardive dyskinesia if someone remains on the medicine for some time. But I personally typically go with aripiprazole as my first line between the two, simply because there's a much lower risk of hyperprolactinemia with aripiprazole compared to risperidone. And this is particularly important in the autistic population because we now have data showing that kids with autism actually have lower bone mineral density and increased risk for fractures.
And in terms of some of the other side effects that you mentioned, particularly drug-induced Parkinsonism and akathisia, many of the neuromotor side effects, if you will, that we often associate with the SGAs, do you see a difference with regard to risperidone and aripiprazole in the ASD population, or is that something that's more dose-dependent and related to, say, for example, 2D6 metabolism or other factors?
I don't see a huge difference between the two drugs in terms of those extrapyramidal symptoms. They both certainly can cause them, and they do seem to be dose and duration dependent.
With regard to these SGAs, do you have any guidance in terms of the monitoring, particularly with regard to metabolic monitoring or other guidance in the ASD population that maybe is a little bit different from the adult population or from the population perhaps who has other conditions that we may be targeting with these medications?
Well, I think in general, we want to be monitoring weight early and frequently. So certainly getting a baseline weight. And then after starting an antipsychotic, we want to be monitoring weight at least once a month for the first 4 months. And this is important because early weight gain is a predictor for the overall amount of weight that will be gained on a medication. And I think this is particularly important in children with autism because, as we've talked about already, routines are very important for children with autism. So changing things in one's lifestyle, like introducing exercise or changing a child's diet, especially if they have very limited diets or have sensory issues which contribute to a limited diet, can be really, really tricky. So once weight gain has started, it can be quite difficult to intervene with those classic lifestyle interventions.
Do you have any thoughts in terms of pharmacologic strategies? I'm thinking about things like topiramate or metformin or even perhaps the GLP-1 receptor agonists.
So the only of those three medications, the one that we have data on in the autistic population is metformin. And there's actually a really nice randomized controlled trial that metformin is helpful in curbing weight gain associated with antipsychotics in kids with autism. So that's typically what I start with.
Something that you said earlier really struck me, and that is the importance of these routines and how that may actually interfere with some of our ability to manage side effects, particularly around eating or exercise or lifestyle changes. I'm curious in terms of maybe those situations where an SGA has substantially increased appetite and we're doing everything we can to manage that pharmacologically. Do you have any tips as somebody that works with a lot of individuals with ASD? Perhaps how to manage that or simple things that we can recommend to parents?
Yeah, it's really, really tricky. I think weight loss is difficult for the general population and probably even more difficult for kids with autism. In terms of lifestyle interventions, one little tip I have is incorporating the child's special interest. Almost everybody with autism has something that they're really, really interested and passionate about. And if that can be weaved into some form of physical activity, that can help. I'd also say that in terms of expanding diet, that is something that really takes a slow and steady approach and a lot of commitment. So I remind parents that you need to try a new food 10 times before a child can get used to it, and maybe even more times in a child with autism. One little trick I use for expanding variety of diet in kids with autism is something called chaining. So pairing a new food or less preferred food with a food that the child eats regularly. So, for example, if they eat eat a lot of pasta on a regular basis, adding a little bit of tomato sauce onto that food that they're already familiar with. And you can build a chain in that way.
Oh, I love that. I love it. Let me shift gears here in terms of other side effects with the second-generation antipsychotics in the ASD population. We talked a little bit about drug-induced Parkinsonism, akathisia, and some of those neuromotor side effects. Certainly, we often try to do things like decreasing the dose to lower exposure, or perhaps even sometimes not the preferred strategy these days, but using an anticholinergic or a beta blocker. Could you maybe help our listeners and me as well understand a bit more about how you as an autism spectrum disorder expert manage those symptoms?
I don't think that we really manage them any different than we do in the neurotypical population.
And do you notice any, increased sensitivity to the beta blockers or to side effects of those medications, which again, we're introducing to manage a side effect?
Well, my hunch is that people with autism may be a little bit more sensitive to extrapyramidal symptoms than other kids. But once we're in the realm of using beta blockers or anticholinergic, I think that the response and tolerability is pretty similar.
Let's maybe shift away from the second-generation antipsychotics into some other classes of medications that you've alluded to earlier, particularly the alpha-2 agonists. I know that you mentioned often using guanfacine extended release to manage some of that irritability or even aggression. I assume that maybe you do that with regard to ADHD, but in general, could you talk about the role of other medications outside of the second-generation antipsychotics in ASD?
So we've talked about second-generation antipsychotics, alpha agonists. I think they have a pretty big role in working with people with autism. I use the alpha agonists for treating ADHD symptoms, sometimes irritability, on occasion sleep. A class that we haven't talked about yet is the selective serotonin reuptake inhibitors.
Let's talk about those.
I think that we have to use selective serotonin reuptake inhibitors really cautiously in patients with autism. And this is so tricky because it's really the class of medication where we have the largest amount of data for pediatric mood and anxiety disorders. In kids with autism, though, we have high-quality data showing that SSRIs really don't help with the restricted repetitive patterns of behavior, and kids with autism certainly are at higher risk for experiencing behavioral activation.
And when you say behavioral activation, what do you mean there?
So kids getting little or a lot more energized, so it can quickly turn into looking like irritability. So kids that are really prone to quickness to anger, having too much energy, trouble sleeping, becoming more anxious.
And in terms of when you run into that side effect, which sounds very similar to what we see with activation in a neurotypical population, what's your strategy? What do you do?
So the first thing I would do is I would try lowering the dose. But oftentimes where we get stuck is even the lowest dose creates behavioral activation or really a starting dose. So you're lowering it and then you're not at a therapeutic dose.
So certainly it sounds like activation may be more likely in patients with ASD in whom you're using the SSRIs. I'm curious if you notice that same risk with the SNRIs or if there are other issues there in terms of just evidence or other factors that perhaps steer you away from those.
Right. Well, one thing that I'll just add is I think there are probably certain subgroups of people with autism who are at higher risk for behavioral activation. So similar to neurotypicals, the younger the child, the higher the risk for behavioral activation. We don't see as high rates of behavioral activation in adults with autism as we do in kids with autism. So I think that's something that's important to keep in mind. Based on clinical experience, I think we typically expect to see more behavioral activation and intolerance of SSRIs in people with more severe autism, so people with more level 2, level 3 autism. and folks with more cognitive impairment. I'm glad that you raised the issue of SNRIs, because that's often what I turn to when, classically you're wanting to use an SSRI for an anxiety disorder or a unipolar depression, but that's just not well tolerated. We see a lot less behavioral activation with the SNRIs.
What about other side effects with if we can still use this term, antidepressant medications, in terms of GI side effects, in terms of headaches, in terms of those other things that we generally associate with SSRIs?
I think that's a tricky question in the autistic population, and one that parents bring to me all the time. I often work with parents who are quite fearful of trying any psychiatric medication for that matter, because they say if there's a side effect, I don't think my child will be able to reliably report it. So I think that's really a limitation in all of autism clinical trial work, where it can be hard to know for sure what side effects are occurring.
Could you maybe tell us a little bit about how you approach that conversation with parents or with families? Because I certainly understand that there is a lot of trepidation in general around these medications, and particularly in a population where there may be worse tolerability or there may be a lot more uncertainty in terms of the actual benefit. What do you say to folks?
Yeah. So when patients come into my office with those concerns, I usually try and understand what their biggest behavioral concerns are and think with the family, what would the potential risks of using a medication be, and what would the potential risks of not using a medication be? So we really try to understand how bad is the behavior, have they exhausted other treatment strategies, and if nothing changed, would that be better than the risk of a side effect? I also remind families that when we're trying a medication, we're not necessarily committing to it for a lifetime. We're committing to it for as long as the medication is helpful.
That's very helpful. Dr. Thom, I know that you've done a lot of work with probably one of the medications that I get asked about the most whenever I give a talk on anxiety disorders. And I know exactly that you know what I'm going to ask about, which is Buspirone. It's been around forever. It feels like we always use it, regardless of the condition, as a third or fourth line intervention. The evidence is mixed. I know you've done actually some of those very important studies in the ASD population. Can you tell us what you found and also what it looks like clinically?
Yeah, that's such a good question. The evidence really is mixed because we know that Buspirone is FDA approved for generalized anxiety disorder in adults and can be helpful, but that there were really failed trials, or rather negative trials, in the pediatric population. Funnily enough, Buspirone's actually the medication that we have the most positive data for in anxiety and autism. We don't yet have a randomized controlled trial, but we now have several open label and retrospective studies showing that Buspirone can be helpful for treating anxiety in people with autism. And based on that data and just my clinical experience of the high risk of behavioral activation with SSRIs in children with autism, I often will think about using Buspirone as a first-line medication for anxiety. In our clinic data, about 60 to 70% of kids treated with Buspirone for anxiety who also had autism had a positive response. It tends to be very well tolerated. And really, in a population where autism is a chronic disorder, we know that kids with autism have higher risk of having mental health conditions, about threefold higher chance of mood and anxiety disorders. This is a population that may need to be on medication for a long time and may need to try multiple medications. So for families who are coming to me for the first time, I really like to capitalize on a medication that probably worst case scenario, nothing will happen. If you start a family with an SSRI and there's a really bad side effect, which is really scary behavioral activation, that family may never want to try a medication again. So for those reasons, I often use Buspirone as a first-line anxiety medication in my population.
And could you walk us through how you dose that? maybe in a pre-pubertal child versus a post-pubertal child, or perhaps based on other characteristics that you consider in dosing?
Right. So I typically I actually use the same dosing regimen in all of my patients because I haven't found a great way to predict what the optimal dose will be. And we saw this actually in an open label trial of Buspirone for anxiety and Williams syndrome that we did. There was a very wide range of optimal dose. So I start at 2.5 milligrams per day, and I increase it by 2.5 milligrams each week in twice daily dosing. So 2.5 milligrams in the morning for week 1, 2.5 milligrams twice per day for week 2, 5 milligrams in the morning, 2.5 in the afternoon, week 3, and so on and so forth, until there is some benefit. And I typically max out around 15 milligrams twice per day. If I'm really not seeing any movement at 15 milligrams twice per day, then we usually move on.
So again, it sounds like you're using much lower doses than what we would perhaps use in certainly an adult with generalized anxiety disorder, perhaps even in an adolescent with generalized anxiety disorder or some other anxiety-related condition. Buspirone is one of those drugs that for me is just fascinating, and I think we've talked about this before at NEI. The data around Buspirone for pediatric anxiety disorders, specifically GAD, are really a mess. One of the things that we know from those data, which we actually requested through a Freedom of Information Act request from the FDA, is that those trials were conducted to satisfy a PREA requirement. And one of the things from that era that's really important for our listeners to remember is that there wasn't a requirement for those trials to be well-designed or well-implemented like the trials that you do, Dr. Thom, but rather simply that a trial needed to be done. And so if we look at the outcome measure for those generalized anxiety disorder trials in pediatric patients, again, children and adolescents, they essentially added up all of the symptoms from the DSM, and that became the measure of anxiety. Again, that doesn't capture the impairment, that doesn't capture the frequency of the symptoms or the severity of the symptoms. So we have a trial that really lacks many things that we would want to see in terms of implementation, and probably is perhaps more of a failed trial than a negative trial, which is really unfortunate given the dearth of treatments that we have for children and adolescents in general. Maybe we can shift gears for a bit and talk about something that we don't talk about enough, at least in my opinion, which is polypharmacy. And I know that you see a lot of patients coming to you from all over the world for consultations. Can you tell us a little bit about how polypharmacy happens in this population and how do you manage it? How do you attack it?
Yes, I certainly do see a lot of polypharmacy in my clinic, and you can kind of understand why. It's a really complex population. We talked about how, although there really aren't medications for the core symptoms of autism, sometimes we wish there were, and sometimes the symptoms are so severe that we feel compelled to try something. And we know that people with autism have a really high risk of experiencing comorbidities. So it wouldn't be unusual to be a person with autism and ADHD and a mood disorder and an anxiety disorder. I think another factor that leads to polypharmacy is when you have really ill patients, it can be really hard to take anything away. So you kind of stack, and the patient's not getting any better. But it's hard to take things away when the patient's not getting any better. But then I think sometimes we've run into this situation where a medication may be causing a side effect, which can be a behavioral side effect that looks like a behavioral comorbidity. So you're adding medications to treat side effects of the medications that you're already using. So when I see a patient with polypharmacy, and sometimes these are regimens that the patients have been on for a long, long time, I really try and work with the patient and family best I can to understand what was prescribed when and what the effect of each medication was. Sometimes when you go back and you get that really careful history, it's relatively easy to peel off medications that did not have much of an effect. Other times, people have been on these really complex regimens for such a long time that it's quite difficult, if not impossible, to figure out what was prescribed when and what happened. And in those situations, I'm usually trying to take off medications that have the greatest risk of side effects first. And when I do that, I usually go really slowly, and I tell families that we're actually in a win-win situation, because what will happen is we may be able to get the patient off a medication, such as an SGA with a relatively high burden of side effects, or we'll be able to lower the dose, which decreases the risk of dose-dependent side effects, or we'll know that this medication is a critical part of the regimen.
So one of the things that I'm really picking up on as a consistent theme is the way in which you seem to prioritize side effects and tolerability, perhaps even over efficacy. Certainly not that it's an exact trade-off in any clinical scenario, but it certainly seems like it's something that's very much at the forefront of your conversations with patients.
Absolutely.
Dr. Thom, I know that we're jumping around as we talk about all of these classes of medications. We've talked about Buspirone, we've talked about SSRIs, we've talked about SNRIs, we've talked about various ADHD-related medications, meaning the alpha-2 agonists, the stimulant medications. One of the things that we haven't touched on is the norepinephrine reuptake inhibitors or the other non-alpha-2, non-stimulant medications. So thinking about atomoxetine, thinking about viloxazine, could you tell us a little bit about where those fit into your treatment algorithm, either with regard to ADHD in a patient with ASD, or perhaps just in terms of other specific symptoms that you may be targeting?
Right. So atomoxetine is one of the 3 medications that we have high-quality, positive, randomized controlled trial data for ADHD in kids with autism. So I think there's certainly a role for atomoxetine in treating ADHD. Picking amongst those 3 medications, atomoxetine, guanfacine, and methylphenidate, it's not easy because there isn't a single drug that is clearly superior to the other 2. What I would say is, unlike when I'm treating a child with ADHD and not autism, I wouldn't necessarily always go with the stimulant first, because stimulants are not as superior to the non-stimulants in kids with ADHD and autism. I would say that I would pick a non-stimulant such as guanfacine or atomoxetine first in a child for whom I have concerns about behavioral activation and irritability. So these are the kids who are already really irritable at baseline. I probably would not choose methylphenidate first. That would be a kid where I would be thinking more guanfacine or atomoxetine. For kids who have a significant family history of mood disorders, particularly bipolar disorder, I would really be thinking more atomoxetine or guanfacine first. And then when it comes down to picking between atomoxetine and guanfacine for treating ADHD in this population, one practical consideration is, can the child swallow capsules? Pill swallowing can be really, really tough for kids with autism. And since that atomoxetine capsule can't be opened, if a medication really needs to be crushed, I'm usually going with guanfacine.
And obviously that would be immediate release guanfacine.
That's right. And we talked about polypharmacy earlier, and I don't want to give the impression that all polypharmacy is bad. Many of my patients are on 2 or more medications. And, I actually think there really is a role for strategic polypharmacy when it comes to treating ADHD in people with autism. Inattention and hyperactivity can be such serious problems for people with autism, really making social impairment worse and interfering with access to the psychosocial therapies, as you mentioned earlier, Dr. Strawn. So what I can do as a strategy is sometimes combining a non-stimulant such as guanfacine or atomoxetine with a stimulant will allow for optimal efficacy. The reason being because the irritability related to stimulant seems to be dose dependent. So you want to start really low and go up slowly. And there may be kind of a U-shaped curve where there's a point at which you get optimal efficacy and you don't have irritability. But if you push further, you get irritability with the stimulant. That point where you get optimal efficacy, but you're not at irritability yet, might still be under treating the ADHD, and in that situation, combining a non-stimulant can be really, really helpful.
I really like how you've talked about the complexity of polypharmacy and really the idea of rational polypharmacy. One of my favorite studies in the neurotypical population is that study looking at the combination of a stimulant plus an alpha-2 agonist versus either monotherapy. And one of the things that I took away from that study by McGuff and a number of colleagues at UCLA is that the tolerability of the combined treatment is actually better than either monotherapy, number one. Number two is that you're actually engaging different neural substrates in creating that treatment response. In other words, that alpha-2 has a different target engagement than does your norepinephrine reuptake inhibitor or norepinephrine dopamine reuptake inhibitor. I wanted to maybe comment a bit more on what you said, again, probably drawing a contrast to the neurotypical population, because one of the things that I often see and is often mentioned to me is, why don't you simply use atomoxetine to treat ADHD plus anxiety? Certainly, we know that that comorbidity is there in the ASD population. One of the reasons why I don't necessarily like that approach is that when we look at the actual data that I think really came from MGH, your home, is that atomoxetine doesn't look as good in anxiety or in ADHD as does an SSRI or a stimulant medication for those conditions, respectively. And so we may really be settling in trying to use monotherapy as opposed to optimally treating both comorbidities, which I think is something that you really nicely illustrated there. I guess the other thing that I do wonder about is perhaps this issue of pill swallowing. And for me, when I think about the ADHD treatments, we do have a number that are capsules that can be opened or sprinkled on food, some that are liquid formulations. One of the other non-stimulants, viloxazine, the capsules can certainly be open. But you mentioned that many of these patients may have sensory sensitivities or other things that perhaps preclude that. Does that guide you in terms of pill swallowing versus opening a capsule and putting it in applesauce versus using a liquid formulation or the flavoring? Can you talk to our listeners about that?
It really can. It's such a challenge in patients with autism. Sometimes there can be really practical considerations, like I mentioned with atomoxetine versus guanfacine, where if you really need to crush a pill, immediate release guanfacine is the way to go. I think you've probably heard this expression that if you've met one person with autism, you've met one person with autism. So I don't think that I could give a blanket statement like crushing pills is always better than liquid, which is always better than tablets. I think it's just such a independent patient-by-patient issue and working with families to troubleshoot. I also always try to empower my patients and families to expand the child's repertoire. And just because pill swallowing is a really big challenge now, it need not be in 4 to 6 months with practice. So I actually have many of my patients do exposure therapy around pill swallowing, and you can make it a little bit fun and rewarding and have kids practice just like with any other skill, starting with swallowing very, very small items like sesame seeds or Nerds candies, and then working all the way up to a pill. And really with practice, even I would say the majority of my patients, even those with really significant autism, have been able to be successful.
How long does that process typically take?
It's actually faster than I would imagine in many of my patients, to be honest. I would say weeks to months with consistent practice.
Okay. So not years that we're talking about here. It can often be done quite quickly.
Right.
So over the course of this podcast, we've talked a bit about how we might target symptoms, how we assess those symptoms, and how we select a particular medication to address that symptom or perhaps even that comorbidity. You've given us some really nice guidance in terms of assessing tolerability and reminded us that we need to probably prioritize tolerability in our discussions. But how do we know if the medication's working? And maybe that's something that you could help walk us through in terms of attentional problems, irritability, and maybe also anxiety.
So when we're trying to assess whether a medication is effective, this can be particularly challenging in patients with autism, even those who have the ability, who have normal cognition and normal verbal expression. And this is because it comes back to that core symptom domain of autism, the social and communication impairment, which can make it really difficult for patients with autism to recognize and describe their emotional state, both verbally and non-verbally. So this is particularly difficult with mood disorders. The cognitive profile of people with autism can also make it really difficult for them to take into account the big picture. So when I see people in my clinic, once a month, once every 2 months, or once every 3 months, when I say, so how have things been going since we last talked? That's an incredibly difficult question for most of my patients with autism to answer. How we get around that is before prescribing a medication, I try and talk really specifically with my patients and families around what our treatment goals are. If a medication works well, what can we expect to change in terms of what symptoms do we want to see change or be less severe? But not only that, I'm much more concerned, and I think my patients and families are much more concerned about how will their lives be different rather than anchoring on symptom severity. What would they like to be able to do that they're not able to do currently because of emotional or behavioral symptoms? So we try and be very explicit about those goals, both symptom severity goals and functional goals, even before we start a medication, so that we have something to anchor ourselves to at the follow-up visit. The other tip that I have is because it can be so difficult to see the forest for the trees over long stretches of time between visits, it can be really helpful to collect data. And that's where we come back to those very explicit treatment goals at the beginning. So if the goal, for example, is to reduce the number of times a child needs to be picked up early from school because of some behavioral disturbance, just to note it down every time this happens. Ideally, it would be ideal to get that baseline data even before prescribing a medication, but hopefully to be able to see that come down over time. It's also really helpful to get data from multiple informants. So trying to get data from parents as well as school or other therapists or caregivers as well.
So I really like that comprehensive nature of the approach to really assessing things across multiple domains and really taking a deep dive into function as well as symptom severity. Dr. Thom, thank you again for taking the time to discuss the complex management of these specific disorders and symptoms in patients with autism spectrum disorder. I've certainly learned a lot, and I'm sure that our listeners have as well.
Thanks very much, Dr. Strawn.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.